Hey everyone, my name is Alan Chiem. I'm actually at UCLA, and I trained here as a fellow in ultrasound, and I did my undergraduate training here, and so this is pretty much like my second home. I feel honored, and it's with pleasure that I share the stage with so many of the great minds of ultrasound education, and just from the first few talks this morning, I just learned so much about what other people are doing and how people are thinking about ultrasound in the future. So the topic of my talk is on the evidence behind ultrasound in medical education. I guarantee this would not be an exhaustive review of the literature because that leads to exhaustion, and I don't want to subject you guys to that. I don't have any financial conflicts of interest. The only thing that I want to agree on, that this is a premise of the talk, is that everyone has agreed that medicine is a language. What do I mean by that? You don't learn a language by looking at the dictionary. You learn a language by actually using those words and putting them into speech, making mistakes, rephrasing, et cetera, et cetera. The same thing applies to medicine. You don't learn medicine through textbooks. You learn medicine through understanding the basic concepts of disease and then applying it to your patients. And so this applies to ultrasound very much so. This is the core of active learning, which I'll go into, and this is the core of ultrasound education. And this is really what Dr. Osler pretty much means by his famous quote right here. And then in terms of ultrasound education, just as in language learning, you really want to start young. You want to start at the very beginning of medical school, because just like language learning, the way that you actually get people to adopt something relatively new is to get them when they're really young and fresh and pluripotent. So the objectives of this talk. So first I'm going to really talk about active learning and relate to that the flipped classroom model and how this applies to ultrasound education. And I'll give you some selected literature on how it enhances your preclinical courses, your traditional courses like anatomy and physiology, as well as the clinical skills that we teach during medical school. And then at the very end, I'll go into some of the areas that I think we still need to work on. So a lot of the curricular people may be wondering, what do I need to give up? And I think with this idea of active learning, really very little to nothing in terms of curricular time. So with passive learning, which is what I'm doing to you guys right now, giving you guys a talk, and it's very passive. You'll probably retain 10%, maybe 5% of my talk after about 2 hours or so. And the way that we actually accomplish this this very little difference in the curricular time is actually reversing this to active learning. And the idea is that you make the learner responsible for the didactics, and you could do this through various asynchronous methods, podcasts, modules online, et cetera, textbooks. And then when they actually show up to the classroom, you actually have case-based discussions. And in terms of ultrasound, you also add on the hands-on component. So this is how it works. So again, you shift the didactics from the traditional classroom model to the learner pre-classroom. You can also have a quiz at the beginning of the class just to ensure that the learners are actually getting these basic definitions from the passive learning aspect of active learning. And then you apply these, your newfound definitions and concepts to real base, like case-based scenarios. And what this allows is it allows for application of knowledge, and it allows for the development of fluency of the material. And this also primes our learners to become lifelong learners, right? So all the CME is really based on this. We hear something on a podcast, and then we apply it the next day to our shifts. So this is a very early study on the flipped classroom model. Flipped classroom is not anything new. Like actually, in the social sciences and the Khan Academy, you have several. You just basically have like a text on so many different studies that explore that in the social sciences. In medical education, this is something that is relatively new, and this is one of the few studies that look at that. And so this is a randomized clinical trial of grad students looking at different medical topics like cardiovascular, respiratory, and renal physiology. One group is randomized to just a traditional method, which is the lecture, homework problems, and then exams. And the other group is randomized to the flipped classroom model. So they have a podcast that we record. They watch prior to the class, and then they're giving the quiz just to assure that they actually watch the podcast. But then during the actual classroom time, it's open for discussion. And this really allows them to really apply the concepts to real cases. And what they're able to show is that for all subjects, there's a marked improvement in the exam compared to the control group. Not even close. You're talking about 10 percentage points from a B to a C, et cetera, and a B to A, et cetera. This is, some of you guys may wonder, well, how can we get our learners, our new learners, to actually do asynchronous education? The answer is that they're already doing this. They're doing this all the time. In terms of our residents, you know, they're the first to know about like MRAP, and they're first to know about EM-CRIT. They devour asynchronous learning, and this is one study that shows this. So basically 98% of our emergency residents, and I think this applies to most residents as well, they spend at least 1 hour per week on asynchronous learning. And what's more significant is that in the star columns, these are actually podcasts. So these actually pretty much equal the same amount of time that they spend on textbook reading. So they're really capturing most of their asynchronous learning via podcasts and online modules as opposed to texts. How does this work for ultrasound education? So ultrasound education actually has two domains, right? So you have a cognitive domain and a psychomotor domain. So the cognitive domain you can really pattern into a podcast or learn module before the classroom. And then with the active learning component, you actually do both case-based learning to apply the knowledge, but you also teach the psychomotor. So for instance, we're looking at cognitively a AAA on the left side of the screen right here. We're looking at some of the bifurcations of the aorta, which we all teach. And then on this side, we're learning how to avoid bowel gas when we teach aortic ultrasound. And you can't really teach that in a podcast. You actually have to teach patients or our learners to be able to scan this on patients and all the models. So how does it improve anatomy and physiology? That's one of the questions that you may ask. So just from a very logical standpoint, most of us went through this during medical school. We have diagrams of the heart, we look at Netter, we see Netter open the heart up, and you guys remember those flow diagrams about like the blood flow of the heart, et cetera. That's how we're actually learning, or that's how actually I learned cardiac physiology. And then when I was in the anatomy lab, I was able to actually kind of develop that three-dimensional understanding, but then I had to put the function from the textbooks into the three-dimensional anatomy, and I had to actually imagine how the heart actually worked. Imagine this, where you're able to not only show your learners, your medical students, how the heart is actually pumping in real time, but you're also able to teach the phases of the heart. So blue is going away from the top of the screen, red is going towards the screen, and we're actually demonstrating diastole and systole right here. This is so much more elegant to be able to show to our medical students than to tell them there's an S1 and S2. They all matter, but in the general scheme of things, I think you'll see that most of our students respond to this more. And here's proof of that. So this study is actually 20 years old, and this is what they did. They actually looked at teaching M mode and B mode echocardiography to students, and they asked them, in terms of helping you to learn better the cardiac physiology and anatomy, which was the best modality? And you could see that essentially echocardiography was highly rated compared to some of the other modalities for teaching cardiac physiology. This is a more recent study where it's a little bit more complicated, but they actually had first year and third year medical students, and they taught them both normal and abnormal physiology or pathophysiology, including things like aortic valve dysfunction, mitral valve dysfunction, LVH, systolic dysfunction, and pericardial effusion. And on top of that, they taught them 7 different echocardiographic views, and they tested them basically on how well that improved their knowledge, as well as how well just basically after a longitudinal course, this improved their ability to obtain some of the views. So in terms of phase 1, these were just first-year medical students, whereas phase 2, they're randomized to very small groups of basically traditional lecture model. This is a flipped classroom model, and this is completely self-directed learning. And really what they're able to show is that there's essentially no difference in terms of the different groups, but there's a much big jump in the change of how much knowledge they were able to gain from this. And more significantly, they were able to show that these medical students, these first and third year medical students, were able to attain these views with some pretty good accuracy, 80%, 90%, et cetera, et cetera. This right here is the mean quality, and you can see that the quality is not that great, but there are two reasons for that. One is that the actual echocardiographers, people that do this all the time in the cardiac suites, they're the ones that were judging the image quality. And two, so they're used to getting these brilliant images, et cetera. And two, the students use handheld ultrasounds. So you're not going to get this, if you're looking at a facsimile versus a 12 megapixel image, you're not going to be able to rate them the same way, but that's what they did. So this is another study looking at this. This is looking at how the perception of medical students with the introduction of ultrasound for cardiac anatomy and physiology. And what I really want you guys to see is that basically 98% agreed that it was very useful, and a large proportion, over 85 to 90%, that it improved their understanding of cardiology or cardiac anatomy and physiology. And in addition, in terms of their motivation to learn more, over 80% said that they actually felt compelled that ultrasound education really encouraged them to learn more about cardiac anatomy and physiology. And if we go back to the video clips of that, you could see why. You could see that this heart that is pumping and functioning in real time is such a beautiful structure that you can't capture with traditional learning and traditional anatomy of prosections nor physiology texts. So this is Dr. Bonner's house right here. I really like this study because this is actually looking at this is another study looking at medical students and how they were able to obtain some images that are clinically relevant, as well as some that are related just to anatomy. And what is really nice is that I want to show you this one right here, is that they are able to correlate some things like this anatomy prosection of the biceps tendon right here, into the sonographic equivalent. And this is what you really want. You want to be able to say, okay, are they actually really understanding that this ultrasound image or clip corresponds to something that they're seeing in real patients? And this study shows that this is the case. Now, this is a European study where they're looking at the European medical system with 7 years of training. And they also taught them various exam findings, but this is more related to GI and abdominal ultrasound. And what they were able to show is that first, one, most of the students really were interested in ultrasound. So this is the pre-mean from scale 1 to 5. So they agreed that they're motivated to do ultrasound on patients. Roughly, it's almost a 5 right here. Didn't change after ultrasound intervention. This is a good thing, right? Because sometimes some of our educational interventions, they do not really appreciate, and they rank it lower afterwards. And what's more important is that they were able to say that they enjoyed the training and it improved their understanding of pathophysiology and anatomy of internal structures. So the take-home point is, again, this is not an exhaustive review, but I can definitely provide you the references. There are over 30 positive studies looking at this, where it definitely enhances anatomy, physiology, and some of the organ-based systems understanding. And this applies to both junior medical and senior medical students. The most important aspect of this is that there needs to be an active learning component, which is the flipped classroom model or some equivalent of that. So let's go to physical exam, and I know that for some of us it may be a controversial area. So think about it this way. So you have cardiac auscultation, which is sort of a keystone in terms of medical school teaching. We all are taught how to auscultate during our preclinical and clinical years. And let's say you have this example right here. So you hear a murmur in the left lower sternal border, it's pansystolic, increases with inspiration. Who knows what this is? Raise your hand if you know what this is. That's fine, because I actually had to look this up myself when I was preparing for this talk. But it makes sense. If you look at the heart, you look at where the stethoscope is, and it increases with inspiration, you have an idea that there's definitely some valvular pathology, and based on the location, that it's probably the right side of the heart, right? So if you did that and you actually pointed the ultrasound probe, you would get Carvalho's sign, which indicates tricuspid regurgitation. So this is how we plan to teach ultrasound with physical exam findings. We want to show them cardiac auscultation, but we want to confirm that with ultrasound findings. And just doing that, like, students are already gravitating towards ultrasound, bedside echo, et cetera. If you're able to confirm what they're listening to on the stethoscope with ultrasound, it just improves their understanding of auscultation as well. So this study was cited by Dean Clayman in his talk, and it's cited pretty ad nauseum in a lot of our circles, but it's a very important talk or a very important study because it shows how well the medical students with about 18 to 20 hours of training do compared to board-certified cardiologists with their stethoscopes. And you can see just across the boards in terms of left ventricular enlargement, diastolic function, left ventricular hypertrophy, et cetera, right atrial pressures, pulmonary hypertension, and then also valvular and all the murmurs too. The medical students definitely are much more sensitive or specific or both than the cardiologists. This is another study that was cited by Dean Clayman, but this gives you a better idea of what he was talking about. So this is looking at liver span with medical students, first-year medical students, compared to attending internists, GI specialists actually. And this is what the GI internists or gastroenterologists estimate in terms of liver span right here. This is the reference standard right here in the triangles, and this is the medical student standard with ultrasound. So basically this makes sense because you can't palpate a liver directly, right? You have to go through skin and soft tissue. And so we understand that tactile differences are a matter of subjectivity, whereas if you actually have you are able to visualize something through the skin, you can definitely make an estimate and measure it. So this is another study that randomized medical students to pre-ultrasound, immediate ultrasound after their passive learning versus delayed ultrasound, and they assessed them at 2 points. First, at the midpoint of their block, and then at the end of their block. And what I wanted you to show is that there was actually very little difference, but we do see a trend towards improvement in the delayed ultrasound block. And this kind of goes into this idea that your physical exam is also somewhat of a passive learning modality. You're telling them that the liver is here, the spleen is here, the heart is here, the right side of the heart is here, left side, et cetera, et cetera. And with ultrasound, they're actually able to take that and apply that to their physical exam findings. So it actually helps them to improve their fluency in the physical exam. And this study just came out actually in January. This is Dr. Din's study right here out of Loma Linda, where they're able to compare two groups, one group that did not have ultrasound training and a group that did. And these are large cohorts of basically the essential class body per year, and they were able to demonstrate that in terms of their OSCE scores, the pre-ultrasound group had about 11% that had outstanding OSCE compared to almost 3 times as much. On the flip side, only 5% of the post-ultrasound group, the group that had ultrasound training with the physical exam, only 5% actually needed remediation compared to over 25% right here. So you just can't compare. So we've known from emergency medicine that you can blend ultrasound in a clinical rotation like emergency medicine, and we know that the ICU is doing this as well. We've been doing this for a long time, and that is the reason why we can do this. The ED is a right place for ultrasound because you have undifferentiated patients with acute pathology. And on top of that, we've been doing ultrasound for over 2 decades. So we have fellowships in emergency ultrasound. We have residencies that all teach ultrasound from day one. And that's why we're able to really integrate this in clinical rotations. However, in a lot of clinical rotations, there is an element of treading on thin ice. And for my institution, there are some major issues that we still need to overcome. One is just decentralization of clinical sites. So UCLA has something like 20 clinical sites for the 3rd year. How do you incorporate ultrasound for every single site when you, number one, have a shortage of clinician instructors, sonologists, to be able to teach that, and number two, you want to be able to really get these clinician instructors or clinician sonologists to teach this way, because the learners are their students. So if you get them to learn ultrasound via sonographer or via a different specialty other than the specialty that they're rotating in, it doesn't lead to this idea that ultrasound is part of their clinical practice, and this is what we need to get to. And so when you have this gap in training for this clinical year, you do have issues with knowledge and skills retention, as well as competency assessment later on. This is one clear example that they looked at 2 groups, case-based active learning versus traditional lecture model, and they taught them some ultrasound didactics. And the first plot right here is immediately afterwards they were assessed on how much of the knowledge that they had retained, and it was 40% for the case base and about 20% for the traditional lecture. Now, if you give them 2 weeks and you go back, essentially there's no difference, and it's essentially less than 15%. So 12% of knowledge retained at 2 weeks. And so this is where the more asynchronous methods to retain knowledge and skills are vital to ultrasound education. There's definitely multiple modalities out there, but I'll actually highlight a couple. This one is actually this is developed by some UCLA researchers, and this is something called a perceptive and adaptive learning module, or a PALM, and it's a computerized course or a computerized module where essentially they're doing this at home, they're doing this while cooking, whatever, and they're able to demonstrate that when you use the PALM versus traditional learning, you actually do improve much better than this reference standard right here. And in terms of student perception, you could see that the vast majority wanted more of the PALM, and that it increased their confidence definitely or somewhat. So this is one example of a PALM for ultrasound that we recently developed at UCLA. And again, it's all online. They log in, and basically what they're doing is that they're learning structure as well as different echocardiographic views, and they're tested on their response time as well as their accuracy. So the idea is that if they're responding within a set time period and they're more accurate, like 90% accurate with the same view or same structure in hand, they will retire that module or that subsection of the module. So the way that it works is that, like, for instance, if you want them to learn the pericardium, you have 5 to 10 different images or clips of the same peristernal long axis view as well as peristernal short axis, apical, subxiphoid, and let's say they get this 90% of the time. So this is retired, and then they go on to the different other subsections of whatever you define as a core objective of the module. This is something else called space education. This is it's actually a commercial product, but you could definitely self-develop at your own institution, and they're basically case-based questions that are delivered to tablets and smartphones, and you set the frequency of delivery, so you can decide that they're going to be delivered every single day versus every week, depending on how they're doing. And the idea is that you can longitudinally improve retention as well as monitor their performance over time, so that, let's say, during the second year, they're really strong with ultrasound because they've gone through multiple labs, et cetera, but then the third year there may be a drop in ultrasound education. You can still use this model, and you can, so this is an example that where they're answering a case-based question right here. And this is, so Dr. Kerfoot is actually at Harvard. He's a surgeon who developed this, and he actually has published about 30 papers on this. And this one is actually on the surgical clerkship. So they were given 1 week of urology training and nothing else until the very end when they were assessed for this. And they had two groups, one that didn't have the space learning or space education, and this is a group that did have that. And so depending on when you actually did the surgery clerkship at the beginning of the year versus at the end, they all had an end of the year exam, and they were able to show that the effect size was significant in terms of the longer the duration of no training in that domain. So this, I'm wrapping up right here. So competency, as Dr. Bonner mentioned, and you know from the audience, there definitely is a lot of debate with that. In terms of ultrasound, we traditionally have relied on knowledge assessment via quizzes and as well as direct observation or OSCEs. And then with ASEP, you know, we have this number 150, which also has been adopted by AIM, 150 scans during residency to develop some sort of general competency in bedside ultrasound, with 25 for the core exams like the FAST and ECHO, et cetera. But you know, it does make sense that we really, some ultrasound exams are much more difficult than others, and so the numbers should differ by application. And my question is, is there something else besides a general core number that we need? This is a paper that just came out this month, and this is a must-read paper if you're interested in emergency ultrasound education or bedside ultrasound education. And what this was it was a 7-year study at 4 clinical sites with over 50,000 images that were recorded. And the initial sonologist or sonographer gave their interpretation, and then it was reviewed by a fellowship-trained emergency ultrasound specialist, and they were rated on image quality as well as accuracy of interpretation. So you could see that these are kind of plateau curves where there is greater than 90% accuracy and optimal or adequate image quality. And some of the exams you expect that right away there's going to be a pretty flat learning curve. So you don't need to do more than about 50 or so for the FAST before it starts to flatten out. And then other exams that are much more complicated, you definitely need a lot more. So this is DVT ultrasound where it may be a lot more than 75 or 100 and et cetera. And what this really is suggesting is that maybe we shouldn't really look at the gross numbers, but we should be looking at other things that are more specific. So, for instance, this is, you guys know this, sensitivity, specificity, et cetera. For the FAST exam, we probably know what the minimal numbers are for positive and negative FAST, but should we actually teach and assess how many numbers of some of the false positives as well as the false negatives out there? So how many stomach sabotages, and I know these are ultrasound jargon, but how many of these false positives do they need to know before they're relatively competent in the FAST? And same thing with false negatives. And I think this is, just a thought out there. There's no literature. I have no evidence to show that this is better than anything else, but this is something that makes sense to me and hopefully makes sense to you guys. So the take home is that active learning is fundamental to ultrasound education, that ultrasound education does enhance your traditional preclinical courses as well as your clinical skills. And And ultrasound education, often at institutions where you just have to scale up, there are gaps where asynchronous methods like space education as well as POMs can be helpful for that. And then lastly, we really need to think about some more specific metrics for competency. So I'm going to leave, I think, do I have some time for this? Okay. I'm going to leave with a video that we showed our MEC, our Medical Education Committee at UCLA, about the best evidence, which is basically student testimonials and their perception of ultrasound.
How has ultrasound enhanced your learning in the first 2 years?
So with learning and teaching ultrasound, you can really understand anatomy and physiology in a different way than at the anatomy lab or in the lecture hall. And instead of just seeing a static image or one organ at a time, you can see kind of living and moving and breathing in your example patient, what you're supposed to see and what you would actually see in a clinical setting.
Tell us about UCLA's ultrasound student interest group.
So USIG at UCLA, I think first and foremost started with the sessions that were being held through the anatomy curriculum. I think after the first exposure to ultrasound, a lot of the students found it fascinating and wanted to see it more. And I think seeing other schools really get on board with ultrasound in their curriculum and big student-run groups with ultrasound was really empowering. And I think having the support of faculty like Dr. Chiem, Dr. Hussain, and Dr. Stark to really empower our student group to form its own USIG was incredible.
How has teaching other medical students ultrasound been like?
We have done a lot of self-teaching, but then all of our faculty have been there to support us with building our portfolios and just making sure that we have the material down before we go and teach other students. In terms of us teaching our Friday sessions and the workshops, it's been really satisfying to see how excited students are. And one of the best things that we hear is, why don't we have more of this in the curriculum?
How do you think ultrasound will enhance your clinical rotations?
Yeah, so having some ultrasound training during third year would have been a great tool in the physical exam and narrowing down the differential diagnoses. And for example, a patient with abdominal pain, we can quickly check for gallstones and AAAs. And in the ICU, we could have used it as another tool to check volume status in a hypotensive patient. For example, one of the patients that I saw in the ED, she presented with a clinical picture of kidney stones and pyelonephritis. While I was doing my physical exam, I just thought to myself, why not go grab the ultrasound next door and just scan her kidneys, because we just learned that a couple weeks ago on the ultrasound rotation. When I put the ultrasound probe on her, it was just very obvious that it was a moderate hydro, and even showed the attending. He's like, I'm not so sure what this is, and I'm like, I'm pretty sure it's hydro. I saw it on all the images and the videos that we saw, so we did a formal ultrasound, and she did have moderate hydro, and it did change her clinical management.
In addition to procedural guidance, how else do you think ultrasound can benefit clinical education?
Some of the skills I'd like to learn back when I was in medical school was volume status assessment with ultrasound. It's now something as an attending I use almost every day in determining whether a patient's dehydrated, volume overloaded, especially in the settings of CHF, hyponatremia, orthostatic-like symptoms, and it's ubiquitous now amongst our trainees.
So I'd like to acknowledge some of these individuals that really helped out with this study, Dr. Din, Suchi, and Fox. Again, I do have the references for if you guys want 60 studies, I'll give you 60 studies. Just email me. This is our website too, and I'd like to open up with questions right now. Yes?
It's just a comment. This is exactly the kind of information that I need to go back to my administration to sell it. So, thanks.
Great, thank you very much. Dr. Bonner?
Comment, clarifying, you said the 150 exams, you said it was adopted by AIUM. I just need to clarify that for you because it's been a big sticking point. The AIUM for years have had this, the minimum requirements for any physician to interpret ultrasounds is 300 exams, and I think that still stands. It's been a very big sticking point. They've acknowledged that ASAP has made a guideline to say 150 exam and acknowledge that exists, but I don't know if they have adopted 150 exams. Again, this number has been the sticking point of how is that 149 you're incompetent, 151 you are.
Exactly.
So I just wanted to clarify that it's more of a political issue.
Yeah, I think, again, maybe moving away from gross numbers to looking at the different false positives, false negatives, I think that may help our learners to really understand interpretation a lot more. Yes?
Can you comment on when introducing things like asynchronous learning? I mean, I would imagine as a student kind of saying, so I'm going to have my classes and I'm going to be forced to do stuff outside of my classes. How do you kind of bring part of kind of those
Sure.
conversations when that kind of that change happens, getting that kind of the critical kind of moment?
Sure. I think with our first years, we integrate with their anatomy course. And one of the biggest champions is actually our anatomy thread chair, who's a vice chair of pathology, Dr. Stark, Lena Stark. And she is one person who really recognizes that the amount of knowledge that students need to acquire during her block. And so with her in mind, I think she's always said that, this is not going to be a big issue. I think most of our students are already looking online, looking to Dr. Google and Dr. Wiki for additional education. And if we're able to take ownership of this asynchronous learning by developing our own materials, I think they'll actually gravitate towards that.
If I could tag on to that, one thing that we did is when it doesn't actually end up being a big issue, most students don't care, but for the ones that do, we sold it as, we're trying to respect your time. This otherwise would be class time. And we're instead letting you decide when you're going to do this stuff. You can do it while you're doing laundry, whatever, we don't care. And so that was another selling point.
Yes, sir.
So how did you incorporate it into the anatomy course? What did you do?
So we have different blocks that correlate with whatever they're studying during anatomy and physiology. So for the first block, it's they're looking at neuro and they're looking at CNS, et cetera. And so with that first block, we go into introduction to ultrasound as part of the module, but then we also look at things like peripheral nerves, and then we look at the retina and optic nerve, which are relatively easier to obtain for students and have a lot of detail on ultrasound, so it invites them to really learn more. Then our second block is actually on cardiac anatomy and physiology, and so we actually do a bedside echo with them, and we teach them just the 4 basic views and the different structures. And then our third block is GI that we have. So while they're looking at studying renal and liver, et cetera, we teach them the FAST and aorta exams on ultrasound. And mind you, these are medical students that are practicing on each other. So image acquisition is very easy. And they're just impressed by the detail. And then the fourth block that we have right now is on musculoskeletal ultrasound. So we have a module that looks at shoulder, rotator cuff, as well as elbow and triceps, and then some of the extensor and flexor tendons of the hand. And again, these are geared towards first-year medical students because image acquisition is not a big issue, and the value of seeing this dynamic anatomy in front of them really reinforces their concepts.
So then, so in terms of what you're doing, you have the cadaveric.
Yes.
You have, I guess, radiology component as part of it or separate hours, and those
Right.
dedicated hours. And then you have these modules that have the introduction to the ultrasound, looking at the nerves and so forth, that they would look at their own time?
No, so these are actually hands-on labs. So what we do is we have the asynchronous learning, the passive learning. We have a podcast for them that they watch. It's only 20 to 30 minutes, so it's really a small amount of their time. And they're instructed to watch it the weekend before the lab. And then during the lab, there are 4 groups, and so 3 of the groups are actually in the anatomy lab, and they're dissecting and looking at prosections. And then 1 group rotates out to our ultrasound lab. And so they're able to incorporate both the cadaveric displays as well as ultrasound displays. Yes.
Can I
everything at once in the moment, in that particular setting. I think it's hard to do that. It's probably
Right.
one of the hardest things to do is to sort of pull out the 4 or 5, 2, 3 even learning objectives for that particular set of activities.
And we do provide them a checklist of what they should cover, and yeah, they're very straightforward. We respect their time, and so they also have some structure when they go in because they have this checklist. And it's really for them, but they always ask, who do I hand this into? And no, it's for you. This is your takeaway. This is what you learned today.
We have to also sort of, for when we recruit other trainers to help us, it's always important to clarify that to the trainer as well, because they sort of go off script
Right.
and it becomes a little bit chaotic.
Right.
Can I add one
Sure, of
comment to
course.
that? As far as, there's a gentleman named Craig Goodmurphy from Eastern Virginia, and is an anatomist, and is really trying to spearhead a certification for anatomists to teach ultrasound, not to do ultrasound clinically, but to get some type of certification to teach ultrasound anatomy. We're teaching, it's been years and years, but finally they're all come on board, the anatomists, trying to train them on how to use ultrasound as a teaching aid. The anatomists are being pulled in many directions, the time of the curricula is being shrunk. Yet if you look at all the lectures in ultrasound, almost the very beginning of all of them are anatomy. So I think that this coordination between anatomists using the tool to teach, hopefully people are getting more and more on board on that because they see it, they see that how powerful it can be to learn without dissection. And it can be an adjunct to the cadaver.
Thank you for your time.